yes, the only hiccup has been that the gaps between sessions have been probably a little longer than desired. But otherwise, it has been a very well conceived program, and we have loved doing it. We have loved collaborating, and this is Dr. Sachin Kasat's second session, and I usually like the manner in which he, gives his insights and the detailing, whatever topic theme he takes up, is usually brilliant. So you have been an audience to an earlier session by him, and this is on intricacies of provider network management. And I have purposely, consciously chosen him as the faculty. So we had started it, we are finishing it today, and it should be a good session. Please enjoy this.
Yeah, thank you very much, sir. So, with your permissions, would like to start. What we would be doing is something different, being a holiday today for most of us, except for those who are still, I can see a few of us are still in office. So, if you really want to understand what provider networking is, how to create it, what is credentialing, what can be the enrollment part, how to negotiate favorable terms, it's important that we actually do it in a role play scenario if possible. So, my humble request, if any one of you is from a hospital background in the audience.
My request to all the participants is that Dr. Sachin does not take a session which is a one-sided. His is very interactive, and today he's trying something very different on a virtual mode. He wants to do a role play. So I would request some of you to come forward and put on the cameras and also interact, and that is how you will enjoy this session more. That's a humble request to all of you. Please.
Yeah, team, we are also clicking pictures. So, if that is a motivator to switch on the cameras, please switch it on. And this will be, put into our Vidyavrish times. Apart from that, having said that, Dr. Sachin is a very interactive facilitator. We have already noticed that. So please switch on your cameras, respond to questions. And if you have any queries, put it onto the chat box. Rupali will be taking it up this time, and she will be taking up these questions. Thank you.
Thank you. Thank you very much. So, just wanted to understand if any 4 or 5 of you have an experience of having worked in a hospital setup. Anyone?
Yes, sir. I'm Dr. Naval from claim teams.
Great.
My past year experience of hospitals working in trials room in Fortis Escort Heart Institute, Okhla, and Fortis Institute, Shalimar Bagh, New Delhi.
Okay, great. Anyone else? So we have Dr. Naval out here. Anyone else?
We can also raise your hands.
You can raise the hands.
I'll just try to show a raise of hands, or maybe give us a thumbs up on the reaction box.
Okay, so what we can do is, and any one of you who is heading,
Okay.
Sir, I was also from a hospital background. I'm working with Center for Sight Park Hospital.
Okay, great. So we have Bhavya, we have Naval. And any of you who is actually working in the provider networking now? Oh, I think a few of you would be there. Yeah, Christopher seems to be there. Vikrant, great. 2 are there. Anyone else? Okay. So, Ruchika, great. So, we have Naval, we have Bhavya. I forgot your name. Bhavya, right? So, you have been working in which departments in the hospital?
I'm working in trial room, emergency room.
Okay, emergency room. Okay, perfect. And Bhavya?
Sir, in administration.
Administration. Okay, perfect. So, we need someone from the marketing team now. Anyone who has worked or has experience of marketing department of a hospital? Okay, no one is there. Yeah, Christopher ji, your hand is raised. So you have worked with
Sir, my first job is from Apollo Hospitals, Chennai. I worked with an administration department in CTICU.
Okay, great. So what we'll do now is we have got a new hospital which has started. You all may be aware. SDFC Health Services and Critical Services, which has started up in Delhi. So all of you are aware of this hospital. So that hospital is being currently administratively managed by Christopher and Bhavya. And from the clinical sides, the medical director is Dr. Naval. And they are very renowned hospital. The patients want to go there. But then as is practically a situation with all renowned hospitals and facilities, the more the name, the more the premium when it comes to taking the services. And this hospital has been promoted to a large extent with private equity. And as you all know, no one does any business for charity. So if you invested money, you're looking at ROIs. So definitely they want to have good return on investment. So they want more patients and they want more patients with better paying capacity. So this is what this SDFC Critical Services setup is there right now. So Dr. Naval, Bhavya and Christopher ji, you are okay with your roles? Perfect. And then from the provider side, we have this insurance company, SDFC Ergo. So from the provider networking team, we had these 3 persons. So now you have to do the empanelment. So if you can have all 6 of you with your videos on and maybe highlighted on the screen, is it possible if the host can do it? So that we would actually see how they want to join.
Yeah, we'll do that. Yeah. So I'm spotlighting Bhavya.
And the videos have to be on if possible for these 6 persons. So by the time these 6 persons, you get ready, how you are going to be doing the empanelment and how you are going to be deciding whether you really want to join this insurance company or not. And by the time this is coming on the screen, let us go into some theory. So we can use that time. So we'll be talking today about intricacies. So I'm not going to go into what I'll say most of the theory part. The objective which I'm going to be keeping myself is how do we optimize provider partnerships? And I'm using the word partnerships because management would make us feel that, okay, we are superior and the provider is inferior. That's when someone is able to do management or when someone is able to control. But the moment there is a controlling tendency, generally in any field of activity, we find that the one who is controlled over a period of time starts desisting the control and starts resisting it. But the institutes, or I'll say the areas where it is not a controlled relationship, where it is a partnership, where it is an equal give and take, they blossom. And as an insurance company, our objective is to ensure that our clientele, they have effective healthcare delivery. So what can be done for optimizing provider partnerships for effective healthcare delivery? That is something which we'll try to understand all of us together. So that will take care of the topic which is given of intricacies of provider management, network creation, credentialing, enrollment, negotiating favorable terms. So if we have to go back theory part, and definitely I'll be sharing this presentation with almost all of you. If someone is asking for a definition of what is provider management, because that is what the topic starts with. So it is defined by in our books, whether it is MHA books or whether general exercises, or even for those who are doing PhDs in hospital administration. सॉरी, आई थिंक बैकग्राउंड
Please
वॉइस
don't
ज्यादा
mute.
आ रहा है.
Team, please be on mute. Mandeep, please put your mic on mute. Thank you.
Thank you. So the process of recruiting, credentialing, contracting, and maintaining relationships, so all these four parts with healthcare providers within a network would be provider management. So that is how the provider management gets assigned or defined generally. And why it is done? It is done to ensure efficient healthcare delivery, to ensure that we are meeting all the regulatory compliances, and ultimately we are promoting cost effective care. So that would be provider management. So all these 6 people are highlighted on the screen, ma'am? No, abhi tak nahi hua hai shayad. The hospital team and the networking team, if you could highlight them.
I think she is
Spotlight.
finding it, उसके connectivity में कुछ issue आ रहा है.
Okay, 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 okay. So
Same here, यहाँ पे भी आ रहा है. Just trying.
okay. ठीक है, no issues. So what we'll do is, with this background of what provider management is and what is the objective, let us see what these people do in the next 5 minutes. So you are all ready? So the provider team, I think you have to initiate.
Team, who's from the provider? I've been highlighting Bhavya, Christopher. Who's from the provider team?
And myself.
Okay, Christopher, you're from provider. Bhavya, you're from the hospital team. Okay, and who else is from?
Vikrant Sharma.
I think Vikrant. Vikrant, you're from the. I'll highlight you, Vikrant. Give me a moment. Vikrant, you're highlighted.
Also Sajeev.
Sajeev. Yes, I'm doing that. Sajeev. Sajeev, you're on.
Yeah. So let us start. Can someone do the proposal? So generally a question while this highlighting is happening. Open question to everyone. Who does the first part? Who proposes first? We just had the proposal day in this month. So I'm not talking about that proposal. Now here in this relationship of a hospital and an insurance company, who is the proposer generally? The hospital or the insurance company? What are your views? Quick, if anyone can respond. Without putting up your hands, maybe let us have an open session.
Insurance.
Insurance company is what Christopher G is saying. Anyone else has any other ideas? Who is the proposer? Hospital is what Dr. Avishan is saying. Now, this is the only relationship where either can be a proposer. Till a couple of years ago, or even say I'll say a couple of months ago or a few months ago, generally it was always a trend that it was the insurance company and especially the newly established insurance company and the newly established TPAs or the provider networking departments who have been approaching hospitals. But now the insurance has spread to such a large extent that the hospitals know that almost every second person who is coming to their facility, he is seeking cashless. And for that, they need to be on panel of the insurance company. So the now situation is slowly reversing. And with cashless everywhere as a mandate, now the ball becomes, I'll say the field of negotiation becomes in such a way that both need each other. Because the patient says, I want to utilize cashless anywhere. So I'm going to ask the insurance company to provide cashless. And the hospital generally, I'm again using the word generally, in 8 out of 10 cases, would be very unwilling to say no. And they would also be saying, okay, let us see what the insurance company is offering, and we may give the cashless to you. But yes, there will be two, or I'll say 20% of the scenarios where we'll get definitely the hospital who is not yet dependent upon credit patients, who would say, no, we don't need. You pay, you take from your insurance company. You don't want to pay, you take treatment from anyone else, because he knows he's got good occupancy. So the teams are here. So can we start, please?
Yes, yes.
Yeah, I'm waiting. You can start the discussions and the negotiations. So who is going to be the first point of contact from the insurance company? Vikranchi, you will be there?
I think customer should initiate is the team. So
Okay.
we get the permission.
Okay. And from the hospital side, who would be there from the marketing vertical? अरे कोई भी नहीं तैयार हो रहा है.
One team. No, each of them have been spotlighted. Bhavya, I think, is from hospital.
Bhavya from my side.
Yeah.
So if it's hospital by, then I appointed to Bhavya.
Okay, great. So Bhavya, you be from the first point of contact for the hospital negotiation right now. So let us start. So can we have some dialogues between Vikrant and Bhavya ji?
Team, this is live. So we are waiting for your negotiation.
And I think this is also getting recorded.
Yeah.
I suggested Christopher and you are suggesting my name.
Okay, chalega, chalo. Christopher ji, you can start. Sorry. Okay.
Okay. Hello, Dr. Bhavya. I'm representing from HDFC Ergo. This is my proposal to your hospital for an empanelment with our organization. So, would you like to join with us?
Sure, sir.
Bhavya, इतनी जल्दी मान गए?
I think occupancy कम है.
Everyone is busy.
No, as I had said, this particular hospital, it has got good name. They are having premium billing, which is being done. So you are from this setup, Bhavya, Dr. Bhavya, where you are not dependent on insurance companies. Patients are still coming. But yes, patients are having a negative feedback that we would have loved to have a cashless, but we were not given cashless. Because that is the most difficult hospital to be empaneled. That is why we are taking that as a role panel. Someone who needs insurance company, he will agree to anything and everything. Yeah. So can we have the discussion? Ankit ji, I think you are. If someone can mute Ankit, तो वहां से background आवाज आ रहा था. Okay, get it. Yeah. So you can discuss Bhavya and Christopher ji.
Yes, sir.
Bhavya, you are mute or you are not audible.
Christopher proposed a tariff saying that we are getting request from that. So we want to take them on that.
चलो, what I'll do is I'll be from the hospital side, तो शायद जल्दी हो जाएगा. So Christopher ji, I am from the hospital side.
Yeah, fine, sir. Okay.
Yeah.
So from the insurance company, so we have a set of tariff based on the hospital bed counts. So we'll be sharing you the details for negotiation. So we request you to go through it and please come back on it, sir.
So why do you want us to go through your tariff or your rate list? We have been in the industry. We are providing services to our patients. So we have got our tariff. If you are interested, you can go through it and we can consider joining on that rate. And for any delayed in payment, we would like to have some additional payouts being given to us. What would be your payout cycle? We would like to understand.
So
And
normally we'll pay in 30 days.
so I need to add up for the 30-day credit cash flow difficulties which our organization is going to have.
Sir, I'll be very open. If somebody speaks like this kind of rules, I'll be very straightforward. I will straight away I'll reject their proposal.
Perfect, sir. No issues. We can have a golden handshake. Our patients can still pay to us. We'll ask the credit companies who are there, who are providing patient financing. They can pay to them. We can take payment from them, and they can claim to you. We have no.
Sir, if it is most important of your hospital to be part of our channel, definitely we'll come back on it.
Yeah,
we'll
but
see
why
it based on the reimbursement claims.
But why should we join you at all when we are having such an easy option out here? When we don't have to do anything. We simply continue with our treatments.
So this conversation, first of all, I would like to know whether you're approaching tie with the insurance company or you want me to approach.
No, it is up to you. We have got good occupancy. We have got good name. That is why we are having premium billing, which we are doing. Our hospital has been promoted with private equity. So we are not at all charitable. We are here for profit. So our investors are looking at ROI.
It should be on the both the side win-win situation. So simultaneously, we also should not lose our financial credibility, and the same way, it should also be benefited. So first of all, please go through our proposal. Please come back to on it.
No, definitely, that is what we are saying. We are already treating.
Christopher, sorry, but I think Monica Thakur has raised her hand.
Yeah, you can speak.
To add some point. Yeah.
Yes, please, Monica ji.
Ma'am, this is Dr. Bhavya. Actually, my laptop was having some issue. So I have joined from Dr. Monica Thakur laptop.
Okay, perfect. So we can continue, Dr. Bhavya now with Mr. Christopher. So you have understood the background of we being a very premium hospital facility.
Yes, sir.
So let me see how you're going to negotiate an agreement on your terms and how Christopher is going to try to negotiate on his terms. Continue discussions.
Yeah, Dr. Bhavya, I would just like to know how many bedded to your hospital? Because the tariff negotiation will be based on the hospital bed counts.
It's a hospital.
Any example, 100, 200 bedded hospital, super specialty hospital of 100 bedded, 200 bedded, maybe
250 bedded.
250 bedded hospital.
Yes.
क्या हो गया प्रपोजल होल्ड पे चला गया क्या I think as a patient I'm worried I need cashless or I'll port the policy आप मुझे cashless anywhere में cashless दो otherwise I'm porting the policy now the agent is troubling what do we do agent says he is going to lose business अब क्या करें because now the pressure is back on the provider team.
Sorry to interrupt. I'm getting frequent call from the hospital. I'm unable to continue.
It's okay. This is the actual true story of
being morning, right? So many discharges and follow-ups are getting in calls. So that's the reason I'm in between. I'm breaking my calls. So.
No, it's okay. So now what do we do? So what I'll do is now I'll be part of the. We already have Naval out here, na? नहीं आप तो हॉस्पिटल से सॉरी हॉस्पिटल प्रोवाइडर साइड से कौन बचा है विक्रांत जी इज देयर ना
Vikrant.
Yeah.
Hi, yes, Sachin is here. So we want to know that, what are the certification that you have, whether you have biomedical base, whether you have other registration with the MCD. So we need to document to proceed further. And we also have proposal form, which will give you, so that you need to fill it up and share it along with your tariff.
Now, what does a hospital clinician want? The hospital clinician wants to ensure that he does not lose a patient. So Nawalji would like to ensure if any patient is coming to him, he does not say, because you are not providing cashless in that hospital, I'm going to another doctor. So the need of the clinician is that his money should not be reduced. He should get his payout on time. And at the same time, the patient which is coming to him should not be going anywhere else. So he is now creating a pressure on the hospital administration. Monica, I don't want to lose this patient. And there the intermediary created a pressure on Vikrant that I don't want to lose my this insured, because if he goes, he will port the policy, and along with him I may have to have porting of so many other policies. So there's pressure on both the departments in both the organizations. So how do they achieve the objective? Because finally, for both of them, joining hands is useful, but then joining hands at rates which are not favorable is a problem. So what happens
So
in...
we have a solution that for this particular patient, whatever surgery that needs to be performed, whatever medical treatment that he or she requires, we will give it cashless based on anywhere cashless, and we can proceed later with the tariff. So not to trouble the customer, we will not lose the customer. We will maintain a relationship, because a mutual beneficial relationship which we have with the provider also. So we would like to give a cashless.
Perfect, 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 most perfect. This is where few of the private insurance companies are making a mistake, which I'm really happy that you are not making. Because at this moment, that patient is important for both the hospital as well as the insurance company. And so it is always easier that, okay, whatever you are billing, whatever is going to be covered under the policy as per usual and customary, we would approve as a cashless facility. Wherever we feel that your rate is little higher, we may not approve, and we would like the patient to take a call and discuss with you how to have that rate waived off, or whether he would be able to bear it because it is going to be outside the scope of policy. But immediate case, it's always better to give the cashless and close the scenario. अब long term में क्या करेंगे? That case came, that case you have given cashless. What next? Even for the hospital.
So from the provider side, we have a pre-built packages and as per the bedside capacity. So we propose that tariff to them and see what they have, what they say in return. Suppose if they agree or they have any query, they can always come back. So it's a close relationship with communication that we maintain with the provider.
Perfect.
And this is the usual practice that we follow.
Now let us see what happens at the provider end once you have shared your tariff, your packages. So Bhavya and Dr. Nawal, both of you have been in the hospital industry. What do you think happens?
Firstly, I check the tariffs which is provided by the insurance company. If it is fit in my criteria, for example, the cataract surgery, for example, of one of the package, most popular package in the industry, cataract. Approximately insurance company given 40,000. And my desire it is 50, 60, 70,000. So I may I'm given a counter to Mr. Vikram. No, it is not okay, because I'm given a premium service to my customer, my patient. It is a very good hospital, a good infrastructure, located in the center of city. So I think I needed 50,000 of cataract surgery. And I communicated to my associates, Bhavya, please discuss regarding the same. If it's insurance company, okay, 45,000, then we will consider this package. and try to sign all other packages.
Great. Now, anything else that happens? The clinician or the administrative team, the finance team has analyzed the package and they have arrived at a decision whether it is feasible or not feasible. And then they give it back to the marketing team or the TPA management team, and then they discuss further. So generally, this is what the flow is, right? And then somewhere it's a give and take, and then the agreement, and then the closure. So congratulations, you have done the empanelment, but now let us see where are all the areas where we could have done something different. So thank you very much. Thank you, everyone. So, ma'am, we can have them removed
Yeah,
from the. Yeah. So what I'll do is, with this background, let me tell you areas of discussions that arise with whatever was discussed between them. First of all, who has the need? That becomes an important aspect to be understood. Second aspect to be understood is how do we have the need but manage our relationships in such a way that it is a win-win situation. Third is, from an insurance side, we generally don't understand how the hospital pricing works. And those who understand the hospital pricing are able to have a better negotiation. I again reiterate that when it comes to hospital or provider management, what is important is that we have a relationship of partnership. And a partner would always like to see that his partner is also benefited besides ourselves. So there always is a golden point where both of them get a benefit, and we have to make that aware to what I'll say both the parties. So even if we are from the insurance company, if we are able to tell the hospital that this is how, even if you agree to my rates, this is where your profitability will lie, then it becomes a win-win situation. तो ये सब डिस्कशन पॉइंट्स अभी आने वाले हैं. What I'll do is I'll share some theoretical presentation with all of you. So we again go back to this presentation. Hopefully the slide is visible for almost everyone. Yeah, thank you very much. So we have seen this definition of provider management. So then we see this process theory here. So that will go. But now let us understand what are the aspects which we'll be seeing. This we have already seen. So let us see what happens in US healthcare, because provider networking India में तो अभी अभी पिछले 20-25 सालों से start हुआ है. But an area where this is already established is the US healthcare system, where we have the payers, the providers, the patients. And there, while in India we have only 3 types of networking, in US we already have the HMOs, the PPOs, the EPOs, and the POS. And each one has its own unique points. Like for an HMO, where they're concentrating more on primary care physician networking. And it is only through a PCP that the patient can go to any other specialist. So it's like a gatekeeper model. A model, if you remember, which we had discussed in the previous discussions, implemented successfully in India as well when it came to one state government employee schemes in South India, where the private insurer was bleeding. And when this was taken up by a PSU along with a TPA, they brought about this gatekeeper model and the policy turned profitable. So that is where HMOs have its own benefits. The PPOs, definitely there is a flexibility. There is no referral requirement. You have any issues, you have to go. But the difference here would be, because it is not a controlled gateway, generally these providers also charge more. And there is, since the charge is more, the insurers also would like to have a co-payment or a deductible, which is compulsory in such organizations, in such providers' utilizations. And then we have exclusive PPOs as well, exclusive provider organizations. So it is like a PPO, but here what has happened is there is a rate negotiation which is more, and so there is a discounting for the out-of-pocket expenses which is happening. Like many of the insurance companies nowadays have come out with a rider through which they are giving the non-medical expenses back to the insured person. They say we don't deduct it. But when they say that we don't deduct it, for that they are selling a rider. So what is happening is through the rider, a sufficient amount is being collected across all the proposers. And so only when few of them are getting hospitalized, the cost gets adjusted through it. But in EPO, what happens is the cost itself is reduced, wherein the volumes offset the quantum, offsets the expenditure, the fixed expenditure for the hospital or the provider. And so the provider also agrees for a lower rate. So that is where the EPOs become useful. And then we have the POS, which is a hybrid model. So all these are implemented in US healthcare. They have been studied. And when, if you remember the previous lecture which I had with all of you, where we also thought about having a discussion on how the insurance industry has evolved in India. So when India opened up and the TPS came into existence, the objective was to ensure that cashless facilities become more accessible. So that was the primary objective of TPS coming into the picture, the third-party administrators. And for that, the networking started. So if you see today, for a healthcare insurance vertical, generally it is two departments which would determine whether the organization would sustain in the long term or it will be, you can understand what I want to say. And those two most important pillars are the authorization vertical or the cashless processing team and the provider networking vertical. So if these two are very strong, these two are robust, these two are agile, then sky is the limit for the growth of the organization. But for that, we need to bring about certain changes in the way we look at how these verticals are responding. So after US, let us see what is happening in India. So in India, it is very clear. We have the insurers and the intermediaries. And then for a fee for service, we have the TPAs. And the TPAs are doing the networking. They are ensuring the payments to the providers, and the providers are doing the care to the consumers who are expecting quality. And the consumers, because they want to have the risk covered, they are making the premium payment to the insurers. So this is the current health insurance space that we are having in India, where we have networking as something which is happening between TPA and the providers. But now it is a tripartite necessity. So it is insurance company, TPA, and the providers together. And over a period of time, because the credibility of the TPAs has lost, and I'm again using the word directly because the credibility of the TPAs has lost, the insurers want to control or have the final say in the quantum of the payout which is being given. And especially when it comes to the high volume cases, because they have understood that TPAs are generally, though not necessarily, making mistakes in approvals, or where there is a scope for negotiation, repricing that is not being followed. And that is why they generally are having a superseding control over a team. So this is what the current space seems to be in India. And because of that, the hospitals themselves, we are having 4 categories of hospitals in India. So first are definitely the PPN hospitals. So where we have the preferred provider networking. So that is what the definition is of PPN, which GIPSA had started way back. And the private insurers, they have followed up with similar concept. But then unfortunately, the PPN now, and I'm again being very straightforward, is not preferred provider network, but it has become packaged provider network. And as we were seeing the discussion happening right now, we generally have come to the conclusion that if someone is approaching us for networking, or we are approaching anyone for networking, we have to make them agree to our packages. and then we are successful. But then that is not preferred provider network, that is package provider network. So what is preferred provider network? Wait and watch. Second is, there are hospitals which are not PPN hospitals, but they are empaneled hospitals for the MEDICLAIM policies or the health insurance policies. For example, Lilavati, Bridge Candy. Now they are a name in themselves, Tata Memorial. They are a name in themselves. So they actually do not need to abide by something which is not a part of their regular workflow, regular packages. And so they simply said, okay, we'll provide cashless, but our tariff, our services, our decisions, maybe we'll give you discount based upon your volumes. And then that's one negotiation on the volumes, by which you discount on the regular billing. But then they are providing cashless. So they are the empaneled medical hospitals. And at the same time, we have certain hospitals which are empaneled, but they are empaneled only for the mass health insurance, the government sponsored schemes. So here there is no question of any negotiations. The rates are freezed. But then again, whatever are the rates freezed, and because we want to have a better profitability, the insurance companies, depending upon the infrastructure of the hospital and the quality of care which can be provided, grade the hospitals. Now, a mistake which was happening in the discussions, our point of focus was how many beds you have. And generally, we try to grade the hospitals depending upon the beds. The more the beds, it means you are a bigger hospital, so you can be given higher rates. And the less the beds, it means your expenses are less, so you will be given lower rates. This was good to start with a couple of years ago, or I'll say even a decade ago. But then now with most of the persons who are in the insurance industry having also understood what hospital financing is, we also understand that it's not the bed which is the sole criteria which goes into the revenue generation activities for the hospital. What also matters is what is the overall infrastructure. Otherwise, for cataract surgeries with super specialty hospitals, the packages would have been very costly. And for a standalone eye hospital, the rate should have been the least. But then you will find that that single specialty standalone hospital is having better equipment, more experienced doctor, better patient loyalty, better patient footfalls, more need and necessity, more societal acceptance as compared to a department in a larger hospital. So this is where number of beds as a criteria alone for pricing is a big mistake. Now, when it comes to empaneled health insurance, mass health insurance hospitals is all this knowledge cumulatively of different TPAs, government officials, collectively has progressed over the years. And so they have come to a conclusion that there has to be a matrix of different criterias based on which the hospitals are being graded. So right from your quality certifications, your care, your team strength, the quality of the strength, the quality of your team, the strength of your various departments, the services that you have, so many parameters, and especially the care outcome related parameters as well. A standardized template for gradation is available in public domain. And those who are in provider networking department would have definitely gone through it. So while it started its actions right from say 2006, 7, 8 Arogya Shri days, it has got better and better with NHA now having a very good template, which is again available in public forum, which all insurance companies ask their provider networking team to understand. And in fact, when new employees are onboarded in provider networking team and their sessions are conducted, these are the basic facts which are being trained to them nowadays of what all hospital features are to be looked into. And that is where even for empaneled hospital, though the rates are freezed and fixed, if you have certain facilities better, then almost all state governments, they allow for a higher rate to be given. And the insurance companies, because they have the capability and capacity, if they find that certain things are not available, they can always negotiate for a lower rate. And that is why you will see 3-tier, 4-tier rating structure, even for the government mass health insurance schemes, which are completely packaged billing. But this is how it has developed, and it's definitely not on the basis of number of beds. So this is the first takeaway point I request all of you to take. That your categorization of hospitals, your provider negotiations, your provider management will not be on the basis of number of beds alone. And then we have the fourth universe, non-empaneled hospitals, who are very happy with whatever they are earning, who are not at all dependent on insurance flow. And they say, no issues, we don't want to join insurance company. Even if you tell them we'll pay whatever you want, your rate, still they say nahi. Because the hospitals understand the moment you are on panel with an insurance company or a TPA, it means addition of workload for the hospital. Because then they need someone who is going to ensure proper documentation, then sending the documentation to the payer, whoever is there, following up for the payment. Once the payment is come, then reconciling it with the accounts department. And then definitely this is delay which is there. And as we started off in the negotiation, the moment we heard 30 days, 30-day credit line, it's a huge amount. So these hospitals say, we are happy with whatever we have. We don't want to be empaneled. And that is why even with cashless everywhere, though requests come, in minimum, and I'll say average 20% of the cases, we find the hospitals saying no. We don't want to care. So this is where, as compared to US healthcare, where an organization, a provider definitely has to be part of and prefers to be part of either an HMO or a PPO, and luckily, if possible, with the EPO. In India, we have these 4 different providers which are being looked into. Now, even amongst them, we have different billing mechanisms. Now, for any successful provider networking, it is important that we understand the billing methodology as well, of how the patients are being billed. So one could be first, which is very, very transparent. Whatever is done, it is billed. That is a line item wise. So if I'm giving an IV infusion, for that I need to have catheterization done. Or even if I have to say put in a IV also, I first bill for that. And then the infusion charges. So line item wise billing. Second could be procedure wise. So I'm doing a biopsy, a liver biopsy, USG guided liver biopsy. So maybe in a line item wise billing, I could have charges for USG. I'll have charges for the needle insertion. I'll have charges for the biopsy. And then I'll have charges for the histopathology report from it. But I can combine it as a procedure and have a single charge. So creation of this procedure where we note that this is a standard collection of steps which definitely has to be done in each and every patient irrespective of the situation, then it goes into procedure kind of a billing. And there the hospital is just simply bundling together the different line items. The eventual benefit being it reduces your billing heads. Third is per diem wise billing. Now, this is very rare. In commercial health insurance, it does not happen definitely. It happens only in mass health insurance or when there are certain situations where the government has mandated it to be paid on a per day basis, as we witnessed in the COVID period or COVID management, or in mass health insurance where we have a per day wise billing for the conservative care cases. But generally, it is rare because look at it from a hospital perspective. When it comes to conservative care, each patient does not require the same kind of a care, same kind of a intensity for being covered, same kind of a medicines which are to be given. It will vary from person to person. And so, per day wise billing is literally very scientifically not possible for a hospital. But then when there is a mandate, they have to accept it. CGHS accept it. ECHS accept it because they don't give any other choice. Fully loaded packages is another area. Now, we generally feel that package billing hospitals accept packages. Yes, accept packages. But then when we have got, say, 173 packages, the hospitals in that published tariffs would not be having so many packages. So what is the reason? So if we want hospitals to accept our packages, we need to make the hospitals understand how they are fully loaded packages. And the most important thing to be understood from the hospital perspective when it comes to packages is you won't make profit margin in each patient, or a fixed margin would not be there in each patient. So fully loaded packages are packages which are arrived at after averaging of the costs historically over a large set of patients. And then this has been a averaged out cost. So it is not a fixed cost. So in certain patients, it will be lower. In certain patients, it will be higher. And that lower and higher would generally be determined on the basis of on the basis of your stay during the surgery in the OT and the amount of medication and consumables that you will be required to be given to the patient. Otherwise, generally the other billing heads are constant. It's only your OT duration and your medicine and consumable requirement, and in very, very rare scenarios, the diagnostic requirement which changes. So everywhere, every surgery where you can average out all these activities and there is very minimal deviation when it comes to your pharmacy consumables, OT duration and diagnostic requirement, we can bundle it out in a package. So when we are sending a proposal to the hospital, agree to the packages, it can make a better sense if we can also bring about a breakup of the packages. Because for a hospital, and since not all hospitals have employed doctors or clinicians, they have to give payout to the doctors based on the patients which are being treated. So that becomes their very first cohort. So when a package is being received for a hospital, they are more worried about how much of it will be going to the clinician and whether the clinician will agree. Second would be historically what has been my consumable usage, pharmacy usage, and whether that can be taken care of here. And then thirdly, the diagnostic necessities. And then you rest are all the billing heads which are the hospital billing heads, be it your nursing charges, the bed charges, whatever we think about it. So if these three are definitely a good part of the package amount which is being given and which can be easily passed on to the clinicians without much headache. Was there any question? I heard some voice. Okay. Then the hospitals can accept it. So in fact, what is needed to be done, or as what we in the initial days of the PPN, what we used to do is when we started off with those 40 odd packages, we actually were going and telling the hospitals how the breakup of those package is. But then over a period of time, even the hospitals, the established hospitals, they have understood, and on a general thumb rule, they have come out that for every package, 20% goes to the surgeon. And then the moment 20% is going to the surgeon, what it means is 6% is going to the anesthetist. And when the moment it is a surgery which requires the presence of even an assistant surgeon, then the ratio changes to 18, 4 and 4. So this is how the hospitals have to be made understood that the package is not arrived at whimsically or just by averaging out your previous historical claims. No, we have understood your billing heads and averaged out the billing heads and then arrived at the package cost. And that means it becomes the fully loaded packages, which becomes easier to be accepted by the hospitals as well. And then we have certain hospitals where we have the open billing system, wherein I can bill for same service anything to anyone. So we have these renowned doctors, especially the cardiothoracic surgeons, billing 2 lakh, 5 lakh for each surgery, as well as billing 20 lakh, 50 lakh for the same surgery. So open billing systems. So this is the universe of the hospitals and billing patterns in India, which we have to navigate and do the provider networking. And here the expectation.
Sir, question.
Yeah, yes.
What is the difference between line-wise and open billing?
In line-wise billing, the hospital rates are freezed. The tariff is published. So if I say cardiothoracic surgery, CVTS level 7 surgery, 2,50,000 surgeon fees, it is a fixed component, line item wise billing billed. But the moment it is open billing, the surgeon can say, I'm billing 8 lakhs for this patient. Or he can say, I'm billing only 50,000 for this patient. Because the rate is not fixed and published even within the hospital. So that is the difference between open billing and line item wise billing. Line item wise billing as compared to open billing is much better, because in line item wise billing, at least we have a transparency. We know the rates which are going to be charged. But in open billing, the rates are completely at the whims and fancies of the person or the provider who is making the service available. So from an insurance perspective, having hospitals on PPN, best. Having empaneled hospitals, second best. Because in empaneled hospitals, we know there's no open billing allowed to anyone. So that is how this universe has to be understood. This becomes the starting point for any new employee who is joining a networking vertical, who has to understand these basic aspects. Because the moment we know these basic aspects, we know how to overcome the problems which we are going to be seeing subsequently. Okay, Rajesh ji?
Yes, sir. Thank you.
Yeah, thank you. So we'll continue. Now, when it comes to provider networking, now the problem is the expectation setting. The expectations which we as insurer or our bosses have, and the expectations which the insured is having. Now, insured, he has very minimal expectations. तो उनको समझना आसान है कि भाई he wants 24/7 services. He wants enhanced facilities, he wants cashless, he wants reduction in claim costs, and he wants also value-added services for free, especially the corporates. But look at the insurer. They want faster, focused claims management. They want lower overhead cost, reduced cost of claim management. They want access to highly trained claim administrators. They want improved control over claim outcomes. They also want cashless, but simultaneously they want safeguarding customer relationships, protection of brand reputation, and control of possible frauds. Now, the provider networking team, whether it be of a TPA or an insurance company, is completely sandwiched between these two expectations. And if they are not able to meet any one of them, it's a problem. तो बोलते हैं ना कि ढोलक है होता है, you can just simply keep on beating it from both sides. So provider networking team is something like that. It's always beaten from the insured as well as the management, because the expectations are completely different from each other. And that is where the role becomes very, very critical. So how do we build strong networks? Because building strong networks is very, very essential, especially for better healthcare. So what needs to be started off is very simple 4-step mechanism. One is identifying provider needs. Second is defining network adequacy. Third is contracting. And then fourth is the maintaining of the compliances. Now the first part and the second part, they are most important. Identifying needs and defining network adequacy. And it is generally here that the mistakes start happening. So again, we go by what we started off in the role play. We gave the example and it was very rightfully managed. In first case, give off. But then as soon as such case has done, it should not be that we become caught up doing firefighting for the second case or the third case. Now, generally the cashless vertical, the authorization vertical and the provider networking vertical, we'll see that they are 24/7. They have no holidays. They have got to be completely available always, all the time. So can there be a situation, can there be a day come in future where they need not do the firefighting? Is it possible? Because if they have to continue doing firefighting always, then what is the use? Firefighting, firefighting, firefighting. One day or the other, the firefighting has to be stopped. So, can that be done? And the answer is yes. It is possible to do. So, how do we achieve it? That becomes the question. And that is where the first two steps, identifying provider needs and defining network adequacy, become very, very important to understand. So we have to understand these aspects. So what is identifying provider needs? Now a provider, as we saw in the example, it is basically not only a hospital, but by practicalities, any service which can be needed by our insured person, and anyone who is able to provide that service becomes a provider by definition. And that is why here you will see that there are certain TPAs who don't have a network only of the hospitals. They also have a network of clinics. They also have a network of diagnostics. They also have a network of doctors, and then network of wellness providers as well. So when today we are talking about provider networking, provider management, what we are interested in is overall management of all these providers and not restricting ourselves to only hospitals. So when we say identifying provider needs, it is common, usually very, very common amongst all these. One, definitely they want to continue with the footfalls which they are getting currently. They don't want to lose the footfalls. So that becomes their first need and necessity. Second is, as we always say, they are there for profit. So they want to have additional footfalls if available within the same fixed cost expenses which they are incurring, so that they can achieve their profit objective. Third is, provider want to have more specialists on their panel. And they want to ensure that whatever is the patient requirement, it gets fulfilled in-house. So each provider would be having this necessity, whether it be a single doctor or a diagnostic center or a hospital or a chain of hospital. And then from our side or the insurance company side, what is the provider need? One, where is the demand for that particular provider? Demand for the provider. So how do we arrive at the demand for the provider? So there are two ways by which the insurance companies understand the demand for a provider. One, by going through the historical claims data of where they have had to pay claims and the hospital is still not in network. And second is having rapid surveys. Rapid surveys within the intermediary network and surveys within the general covered insured population. Which providers do you like to visit and you would like to have on panel for cashless services? Practically, very few insurance companies and TPAs are going for the second part. It's the first part which is generally being resort to what is the historical data. And a shortcut even for that is we generally go with who are the providers in network of other competitors. तो हिस्टोरिकल डेटा का देखने का भी काम हम नहीं करते हैं, especially when we want to build up a network very fast and very quick, because that is the need of the hour. But scientifically and most optimally, what would be done is actually understanding historical utilization, historical demand for a particular physician or a specialist or a hospital. And then second would be amongst how do we determine the need is based on the demographics, geographic distribution, and the service gaps that we witness. Now, if it were not for cashless everywhere, the service gaps becomes important. Are we having a situation in a particular locality where a service is not available, though we may have empaneled 10 hospitals? For example, let us take example of, say, we have Jahangir Hospital which is on panel. We have got NM Wadia which is on panel. I'm taking these two names in Pune. They are there near the railway station. And then they don't have anything. There's a bigger hospital out there, Ruby Hall, but then because the pricing was high, we are not in panel. Now here my service gap becomes relevant, because I know that Jahangir is not going to provide me with opthal services. They have, but then they don't have robust service department for that. They're not providing me radiation services. So there's a service gap. So how do I overcome it? And that is where I look out for providers who may be experts in providing these two services and empanel. So maybe I'll simply go across the road and empanel the Asian Eye Hospital. So my ophthalmologist is taken care of. And for radiation, maybe I'll have the hospital to have a hospital to hospital tie-up with, say, Inlax Budrani or Ruby Hall for radiation services. So that they take services from there, but then they are the primary service providers. So service gaps, geographic distribution of the insured persons, patient demographics, demand for the providers, these four help us to arrive at the identification of the provider needs. Then once we have identified the provider need, comes defining provider adequacy. Because the objective of a networking department is to ensure sufficient manpower, sufficient hospital and provider availability for timely patient access. Like with the GBS in Pune right now and the other issues, we are not having vacant ICU beds available across major providers in the city. And critical patients are suffering because there's no ICU bed available. And the patient has to go 80, 70 kilometers away for an ICU care. So having sufficient provider availability for timely patient access is very, very important. Now, this is something which can be mitigated by understanding the peak load or peak necessity felt for a particular service. So peak load for a particular service, the historical data will give us. And peak necessity being felt is something which you would have to arrive at. But then we need to understand this adequacy, and simultaneously we have to ensure that we are adhering to the state and the central government regulations on this particular aspect. Luckily for India, as of today, neither IRDA nor NHA has circulated any guidelines for provider-patient ratio. But then the time is not far off when this particular thing can be dictated by government. So as an insurance company and an upcoming insurance company, it is better that we start working on this statistic right now. What is my provider-patient ratio for each zone, at least, if not city? And this has to become my marketing drive for getting more business. So I came across a presentation by one of the TPAs who says, we are the biggest providers. But then the whole provider network is concentrated on only one zone in India. So they are not adequate. But then we have a TPA who is transparently publishing what is their general provider count across each city vis-a-vis the patient or the insured persons which they have had. Now, this becomes the kind of service which will be necessary in the long term. So even for in-house provider networking departments, we need to map this out. How many providers against how many insured persons for a particular PIN code. And the moment we find that something is not up to the best level that we have, we need to add up more providers out there if available. Or we need to at least have the system in place wherein we know if a call comes here for emergency and if a provider is not available, what is the nearest other provider who can be mapped for this particular locality or region. So this is how we identify the provider needs and we define the network adequacy. And once this is done, then come the contracting with the providers. Now here, the standard tripartite agreement format is something which has been published by IRDA. So we now need not do individual contract negotiations. The terms, conditions, payment models, policies, they are standardized. So we simply have to execute that. What is required to be done separately is the annexure part, which takes care of the pricing schedules or the hospital tariff and the various other value adds which the hospital would be providing. So how do we negotiate the tariffs? How do we arrive at the packages for this annexure? We'll be seeing shortly. And then the fourth part becomes maintaining compliance. Because it's just not that, okay, you have empaneled someone, it is a part of your network and your work is done. No. With Rohini in place, we need to ensure that the hospital registers for this registry. We have to conduct regular audits. We have to conduct regular performance evaluations. We have to ensure that the provider is adhering to whatever are the state laws and the government regulations. For example, the FATCA regulations. We need to ensure that the cash transactions are minimal, and if and ever the billing is high, then the provider is doing the KYC. This is just one example. So this is how this whole aspect of building strong network for better healthcare consisting of these 4 points comes into picture. And then we move to what should be our principles which guide us in this particular activity. Now, this is also not something very unique. We have been understanding it. Only thing is, we now need to document it at one place and each one agree for it. So as you can see on the screen, first let us see the right part, wherein we have this statement that we need someone with an overview of the situation. And that is where the provider networking vertical becomes very, very important, as they have to ensure that they are having the proper overview of the situation. So which are the key principles that we have to adhere to? One is stakeholder participation. 2, transparency, accountability. 3, capacity support. 4, key level leadership support. 5, paperless environment, technology support. 6, you have to encourage quality. Only one principle I have documented there by paying higher rates. Then monitoring and evaluation. And finally, addressing challenges in time. But a good provider networking department who has taken care of all these aspects, the Ashta rule that we generally follow, has good success rates and very few provider relationship management issues. So let us understand each point in detail. Stakeholder participation. So when we are talking about stakeholder participation, during networking especially, as we saw the times being changed earlier, hospitals, we chasing hospitals, then hospitals chasing us, and now a level field. So what it means is we still have to approach hospitals, or we need hospitals to approach us. And that is where one of the most important stakeholder who should be a part of our eyes and ears on the ground is our insurance intermediary, the agent, the broker or the corporate agent. Because they are at the ground level, they understand what are the needs and necessities in a particular region, locality where they are getting more insured persons. So there has to be a mechanism established wherein they can share their requirements and also share their recommendations for creating more robust network of providers. And then among stakeholders, the providers themselves are an important stakeholder. So there has to be a mechanism by which the providers can approach us. So it need not always be only through the email. It need not be only through the online application form. It can be through a referral route also. So we need all the stakeholders together. And when we have the stakeholders together, what we also need to have is their feedbacks. What are their requirements? What they have witnessed and what they would like to witness or understand more and better in our services. And then we definitely have our own finance team, our own legal team, our own marketing team who are to be involved. So stakeholder participation from everyone becomes very, very important. And this goes hand in hand with the fourth point, which is local level leadership support. Generally, a mistake which tends to be done because this is a scenario where there is more of solicitation, less of solicitation, and more of an approach by the providers. So over a period of time, we have seen certain unethical practices come up at the local level. And so generally, insurers and TPS tend to have a centralized mechanism of networking. But then the moment there is complete centralization, we lose on the capacity part and the stakeholder participation part. And hence the fourth part, which is local level leadership support, becomes important. Because irrespective of an organization who is doing networking, whether it be a TPA or an insurance company, they would be having local leaderships. So though they may not be a part of the provider vertical, still their support has to be actively solicited. The kind of negotiations which can happen across the table, those same results will not get across maybe Zoom meetings or emails. That personal touch is very, very important. And so the involvement of local teams is a must. And that is where few of the insurance companies, the private standalone health insurance, in fact, they have got decentralized provider networking verticals. And they take care of their own zones, of their own cities. And so they have got much, much better results. Because then what it does is it takes care of our second part of transparency and accountability. Because now they are empowered. With power comes responsibility. And so the first responsibility which comes with empowerment is to have increased or enhanced transparency. And then they have the accountability that they cannot have anything going wrong, any inadequacy creeping in, any charges being paid more than necessary. So transparency and accountability is taken care of. And that can help us in having better capacity support. So it should never be a restricted provider network that we are envisaging to be built. It always has to be a detailed provider network. And hence, we need to keep on adding capacity, especially to ensure that if, and unfortunately, if there is any kind of an endemic or a pandemic, there is capacity to take that into account. So capacity support is important. Next is creating a paperless environment. Now, this is not only on the basis of we need the hospitals to do the authorization request directly on our website. No, we have to look much beyond that. We need to have a standardized billing pattern with codes of each hospital and same reflecting in our stored tariffs or the agreed tariffs of the provider. So what it means is if you have to achieve a paperless environment, it does not start with the authorization request coming to us. It starts at the networking level because the tariff which is agreed has to be digitized immediately. And digitized does not mean scanned. Digitized mean that it has to be a part of a proper database structure. And this is where the challenge lies. Each provider, multiple different nomenclatures for department, different nomenclatures for billing heads. But still, we need to have a single database. And then there's also different nomenclatures for room types also. It's a complicated scenario, but easily possible to be covered. Just like crossing over a well or an ocean is difficult, but crossing over a puddle of water which is being created in the hoops because of the hoops of the cow, you can simply jump over. Similarly, paperless environment, if we envisage, may seem very big ocean, difficult to be surpassed. But the moment we break it right from my digitization of the agreed tariff perspective, it becomes easier. What is required is a proper database structure which will take care of the permutation and combination of my room categories in the hospital, because rest everything is same. The service nomenclature of the hospital has to be mapped to a standard service nomenclature. So the first task to be done is by going through the historical tariffs of the hospital available with us, we arrive at what are the distinct service types which are being billed. Second, what are the distinct room types which are being billed? And then against each one of these two, the central provider team has to define what are the actual unique service types, and then map them with the distinct service types against the providers. Unique room types and map them against the different room nomenclatures. For example, when it comes to room types, they're very easy. Something like daycare. Second would be where it is a general ward. So anything and everything where we have more than 3 beds in any of the hospital, that has to be mapped irrespective of its nomenclature to a general ward. The sharing, so either it be twin sharing or 3 sharing. So we will have a sharing, then we'll have a private accommodation, And we have a special private accommodation where you have enhanced. So you can have a private AC, then you can have a deluxe and a super deluxe. So super deluxe and deluxe will become my enhanced private accommodations. And then we have special private accommodations. And then we'll have lounges. So whenever a hospital tariff is coming, I map these room categories. So when it comes to my standardized billing, I know against what it is going. And then whatever are the service ads which are there in the hospital tariff, I map each against my standard unique service names. So my standard unique service names may be say 6,238. The hospital may have only say 229. But those 229, though inputted in our software, will be mapped against 229 in the 6,028. So my digital complete tariff of each hospital becomes available. And the moment any request comes in, it tracks against this digital database. Any deviations, auto email goes, billing not as per tariff. So 0-minute decision. When Max Niva, now it is Niva Bupa, when it had started off as Max Bupa in the initial stages 2010, 9-10, and they were promoting their products. They used to promote as Dil Ki Dhadkan, 30 minutes approvals. But now the days are different. Here the insured, they're expecting 0-minute approvals. And this is possible only with this kind of a digital database being created. So how do we do it? This has to be started right at my contracting level. So once you go there, I'll be talking about it. Then important is encouraging quality. So quality care helps an insurance company because the return to OT and rehospitalization rates, they are lesser. So there is better profitability for the insurance company. So promoting quality care by maybe giving additional payouts, rates, or agreeing to lower discounts, or giving preferential period or credit period terms to the provider, like third day payments. So all these and everything which can encourage quality is important. Monitoring and evaluation is important because finally there's always a moral risk which is involved, the moral hazard. Everyone has to earn quick money. So errors and omissions are expected. Abuse is expected. And that is where monitoring and evaluation becomes important. And addressing challenges in time. Now we have become very used to it because we all are firefighters nowadays. So we address challenges in time. There's no doubt about it. But addressing challenges in time is not what we are doing currently. Addressing challenges in time is when we work proactively to prevent the challenge from occurring itself. That is addressing challenges in time. After the challenge has already occurred and we are trying to resolve, it's not going to give us a go ahead. But when we work to prevent the challenge itself from occurring, that is addressing challenges in time. So that is why it becomes a key principle in provider networking. So anyone who is successful in ensuring the implementation of this Ashta rule or the 8 principle rule definitely has better success rates in the industry. Now, this is possible with good credentialing and enrollment. So, credentialing, we know, is verification of qualifications, licenses, background, and ensuring only qualified professionals they are onboarded so they can deliver proper patient care. But here, what is important is that we verify the providers before they join the network to ensure that they are meeting the regulatory and payer requirements. Because this is the location where we can actually build trust and loyalty. So if you are able to have a network which is clean network, zero abuse network, good quality care network, the patients are going to be very, very happy. And their loyalty is going to be getting converted into better business opportunity for all of us. So credentialing becomes important aspect to be done. So how is it achieved? So anyone would like to volunteer here for expressing what are the current credentialing mechanisms which we are being followed? You can unmute and speak, any one of you. Or is it that no one is doing credentialing?
No, we do it.
Yes.
Uh, we get the market intelligence also. We get a market feedback. We deal with the RLM team also. We take the feedback. We try to find out what are the backgrounds of the provider, who all people are associated into it. We track the previous data also. What are the trends in what kind of a disease and what is the claim size and what is the infrastructure is known. Apart from that, we also focus on what is the locality in which these hospitals are operating. So majorly it goes with the intelligence of the market intelligence.
Okay, good. Anything else? Okay.
As a large language model, I can do.
What is important in credentialing is credentialing always has to be done post your hospital audit report. And hospital audit reports have to be completely app driven or online. It should not be paper and page format where something is being filed up later on. No. So each and every provider that we empanel has to be visited by some official of the organization. It's a must. Because this gives idea of very basic aspects. I had one employee who was trained to visit hospitals, and the very unique criteria he developed after he started visiting me is instead of starting the audits from, say, OPDs or rooms, we used to start our audits with OT, wherein we used to go into the OT and look out for the consumables which are expired, be it betadine or anything. And if we used to find anything, we knew what is to be done. And if we don't find anything there, then it means that we are really in a good place. And from there, we go to see the OT registers. What are the OT in and out time for the patient for the surgeries, and we simply glance through it to understand what kind of service levels have been there, how much time has been taken historically for performing surgeries. And then once we had that idea, overview, the bird's eye view, we used to check the CSSD registers, the autoclave registers in small nursing homes especially. And you just start understanding if all these three are matching. And if they're matching, we know we are into dealing with a good ethical organization. But the moment we find that there's a problem here, we knew we have to be very careful with whatever we see further. So the important aspect is audit reports of complete hospital infrastructure, and I generally recommend that this has to be as per the NHA guidelines which are available in public forum, and that is why I'm not taking it separately as part of the discussions now. You would all be able to download it from the NHA website of how hospital audits are to be done, what all things are to be seen and to be filled in the standard Excel format, which many organizations have converted to mobile apps, be it insurance companies or be it TPS. And there on real-time basis, we take the photos, videos, upload, and then we have a detailed audit available, hospital audit, where we know the complete infrastructure. But this gives us the material aspect of the provider. But the service aspect comes from the staff credentialing. And that is why the next visit is to the HR department, where we generally go through all the providers, I mean to say the doctors, the nurses, the housekeeping staff, especially the mama and the maushis in the hospital. So what has been their experience and their tenure in the organization? And if it is a hospital where it is more of conservative care, then what is the ratio of nurse to patient and doctor to patient? Because this is something which is going to create an important effect on the final outcome. So the moment we have this data, then when we verify the qualifications of the doctors, the providers which are being mentioned. So we have to ensure that the database is created of all the doctors in a facility, and the hospital is also encouraged to intimate to us on a real-time basis for any change in the hospital personnel. By allowing them to do that change directly on the website, updating addition of any new doctors with their qualifications, qualification certificates, the license, and the license end date. And then this database has to be mapped to our authorization request database. So this database, the moment there is a request, and I was talking about that 0-minute decision, if the requirement raised is of a provider or a doctor whose details we have here, and the score against that doctor for historical abuse is still 0, it is to be 0-minute approval which is given. And directly system driven. So it's auto adjudication. We don't need to do anything. So this credentialing is important. And then based on the qualifications and the available infra, which all services can be provided or allowed to be there. Like the hospital may have a gastroenterologist, but no endoscopy set or a no endoscopy room. So there cannot be daily endoscopic claims which can be coming from that hospital unless they have started this facility. So credentialing and having the credentials established in the software is very, very important. And when we talk of background of that providers, what we are talking about is presence of that same doctor, same registration number, same registration council, same registration year in more than one facilities. So anywhere where we have this visiting kind of a scenario, we just simply try to understand whether they actually were present at the time of service or not. Because this is a kind of a outlier analytics which comes out when the data is available in the system. That when 2 claims, 3 claims are coming in of same doctor's name, but there is a time overlap, we know something is wrong. So this database of credentialing available right at the time of pre-contracting, pre-enrollment is important. And credentialing should lead to enrollment. So enrollment is basically a process of registration with payers for claim processing. So we may empanel as a TPA hospital XYZ, but unless we have intimated it with the insurers with all whom we are working and taken their consent, it cannot be called as an enrolled hospital or an empaneled hospital. Because that enablement for payment for the services by having acceptance of the insurer is very, very important. And that is the step when it is told as it is finally empaneled or enrolled. Now, all such providers must undergo periodic reviews as well to maintain the compliance. So even that is a part of enrollment. Periodic reviews for compliance, especially when you talk of reviews, it has to be review of the manpower, review of their licenses, and review of their registration numbers. So we have to ensure that everything is updated with standard certifications. If possible, the hospital has to follow the quality standard and get accredited for NABH or entry-level NABH. And they're also a part of the Rohini network. So यहाँ तक clear हो गया सबको? Anyone has any doubts till here?
No.
Okay. So if there are no doubts, we'll go to the next topic of discussion, which is very, very simple. So this we have covered. Now, in provider enrollment, what is also important is that we are having contract execution. Now, in contract execution, importance is being given to negotiation of the fee structures, payment terms, and participation agreements. So this is where our real challenge starts, wherein we have to make the hospital agree to our particular rates and particular terms and conditions. So how to achieve it? Now the best and the first part is for anyone who has approached us, generally we have been following a closed door policy. Approach कर रहा है करने दो, reminder डालने दो, फिर we'll take it up for discussion. No. Ideal thing would be that if someone has approached, he be asked to feel or he be asked for doing a self audit of the facility by sharing the audit format with him. And that self audit should be followed with a video audit to conform to whatever is updated in the self audit. And once that particular aspect is fed into the software would tell us of where the rates have to be. The nearest provider whose rates match with this provider. And the output, once we know the provider name, we then have to tally whether this provider is having rates equal to or lower than the recommended provider. If they are, again, which is a system-driven check which has to be done, the auto decision that this is good to go for enrollment has to be cleared. Now, this system development is very, very important. And if this is not in the system, it has to be done manually. But each and every provider who has approached us, we need to tell them to get back to us with standard billing format and standard billing tariff format so that we can add it to our databases. So when we are doing this, we face a lot of challenges. First challenge which we generally face is delay in verification. Because this process itself, what we have been doing over the years, is a lengthy process where we are doing manual reviews. So there are huge backlogs. Even now, if we ask any network department across India, कि कितना network अभी discussion में है, the answer will always be more than or equal to 50 and 100. Because it is a lengthy process. And there's always a delay anticipated in onboarding and patient access. So delays is our first challenge. How to manage it is, as I said, with self-audit and video audits. Second challenge is the regulatory compliance issues. Because there are various government, state government and central government regulations which vary from place to place. If the Centralized Clinical Establishment Act, CEA, would have been passed, life would have been much, much easier. But then as of now, it is not so. So non-compliance is something which we generally witness to. And if not acted upon on immediate basis, we'll find that this has led to a lot of network terminations or denials. Otherwise, the network could have been much, much stronger. So we have to handle the regulatory compliance issues properly in the form of ensuring that there is timely responses, timely decision making, and technological intervention. Third challenge that we faced is inconsistencies which we see in documentation. The registration certificate, the licenses, they may be missing or incorrect एक provider का दूसरे provider में. So this all leads to rejections and extended approval times. And that is why I generally recommend to have empanelment requests coming online and getting directly mapped to our databases. So whatever is the provider telling, it becomes a part of my database, and chances of missing any document, any certifications become rare. And if at all any such thing still remains missing, you can simply follow up with the provider. Because now we know at one click what is available and what is not available. So inconsistency in documentation can be easily controlled and mitigated. And then we have certain payer-specific enrollment requirements. Now, this I'm talking from a TPA perspective. I think I have lost. Hello, am I online again? Can someone confirm? I think I had dropped off. Yeah, I'm online. Yeah. Thank you. Thank you. So that is where it becomes important. Because different insurance companies will have different application processes and criteria. And that is why a standardized empanelment scenario across the industry has to be evolved. GIPSA has come together, and that is why they have got very good results. Similarly, I always recommend in all my training sessions that similarly the private insurers also need to come on board together. And for that, I always quote the initiative of the private life insurers who have created a medical networking task force, MNTA, for ये आज का नहीं है. This is there since 2007, 2008 onwards, where they actually meet and they share the provider experiences, the diagnostic center experiences. And together they blacklist also wherever they have come across inconsistencies. And if they come across any new areas where they are having networks, they share internally their feedback. So this helps for anyone to ensure if they are going ahead with networking, they take only those who are reliable. And even they have standardized what all systems they need. Like initially, we all knew the diagnostics, especially in the life insurance, they used to be wash basin diagnostics. Even the physical checkups were hardly ever done. So as a mandate, it came out that we need to have the GIS stat photos of the doctor with the patient. And then the face recognition technologies. So almost everyone has become standardized. And everyone expects the same standards to be followed. Similarly, it is necessary that we have a national medical networking task force of all the employees, or if not all employees, the regional heads of the networking verticals of all the insurance companies and the TPS together. So the forms can be standardized, the tripartite agreements can be standardized. Again, here, everyone has always had a clause that says the hospital agrees that the tariff which is being provided is the least, and if any discrepancy is found, that the hospital agrees to share whatever is the increased rate. Now, this is a part of the agreement, which almost each TPA, each insurance company is executing with the hospital, and still we all know that the hospital is not following it. And the hospital will definitely not follow. Because for the hospital, wherever they are able to get higher rate, they would like to get the higher rates. So how do we manage and overcome this situation? The solution is, just like the PSUs have a GIPSA, it is time the private hospital, the private insurers also come together and they negotiate together. Because negotiations will only give the network. It's not going to be the unique selling point. Unique selling point is still going to be differing for each insurance company based on the capacity, scalability, and excellence of the authorization vertical. So even if we come together for doing the networking, it's not that today I have a brownie point, tomorrow I may not have. Today I have a preferred rate. Why should I share my rate with the other person? But then this is only going to create more hassle. This is allowing the hospitals to play one against the other. And also this creates hassles at the hospital end also, wherein they have to maintain so many different kinds of a tariff for different insurance companies and TPAs. If you ask the hospital, they'll never agree to give the tariff as given to the GIPSA PPN. Because GIPSA PPN tariff is highly subsidized on account of the volume which they enjoy. Now here, individual insurance company going may not be enjoying the same kind of a volume. So there is no, what I say, selling point for an insurance company to ask for same tariff and same packages. But if multiple smaller volumes come together and they together go and approach, then they can have an option of negotiation. You all know the story of the woodcutter whose 4 children used to always fight with each other. So finally, he asked them to go to the forest to bring the wood. And when they came, he asked them all the wood to be bundled together and asked each of the child to break the bundle. None of them could break. Then he asked them to unbundle and asked them to break, and each one could break. These are not stories of Panchatantra. These are actual guiding principles for our provider networking. That our own volumes may not be sufficient to get better terms and conditions or equal terms and conditions. So we need to bide together. That is why that regional heads of all the networking verticals of all insurance companies coming together is very, very useful. Practically, this has already started. There are unofficial WhatsApp groups which you would have also joined. So any hospital gets joined with a particular provider. The provider team is always friends with each other. So they share, I have made him join and this is the rate I am getting. This is the packages which I am getting. And then the negotiation, the hospital also comes to know, okay, they have come to know, then they weigh in whether they need that particular insurance company, they don't need that insurance company. If they feel that they need that insurance company based on the historical claims experience, then they agree. So what remains to be actually done is conversion of these informal discussions into formal forums and then negotiating together. So this will also ensure that there are no pair-specific enrollment requirements and issues which we generally face. But then this is a call to be taken at the industry level. We can only recommend. The decision is left always to the industry to come out with what can be best done for it. But then this is a challenge which can be easily overcome. So again, let us understand the objectives of negotiation. So they are very simple, 3 objectives. We have to have cost-effective provider payment rates. We have to have quality care, and we have to establish long-term provider relationships. So how do we success? First is market research, benchmarking. But market research and benchmarking cannot be whimsical. Benchmarking has to be completely analytics driven. Databases have to be created. Second is understanding provider cost and service value. And this is where we generally go wrong. And this is where our discussions keep on prolonging. And no one gets the benefit. Who gets benefited are the fourth party providers which have come up across parts of India, who tie up with the providers at their tariffs and seek X percentage service charges and at the same time they tie up with the finance companies. And when the patient is treated, they have their in-house authorization departments. They know what is going to be paid, what is not going to be paid. So with taking headaches of the documentation at an X%, which is as less as 3% for the provider's regular billing, they are generating crores of revenues. And that 3% is not being given by the provider to them, but actually being given by the insurance company to them. So rather than allowing such partnerships, we need to understand each provider costs. What is the service value which the provider is bringing? And we need to now agree on the similar conditions. And if you are directly agreeing, the providers also feel better. Because here at least they know there is an entity which is regulated by a government organization, IRDA. So they agree for the similar conditions. And we can then always offer value-based incentive agreements. The provider networking is not only inpatient hospitalizations. The last session we had was case management and care management. Now, this is something which is in the interest of both the providers as well as the insurance companies. So, we need to have value created from the providers by getting them to provide free care management services. So the moment they agree for free care management services, it's a win-win situation for us, wherein our patient is getting free consultations, free follow-ups, free reminders for medications, and discounted OP investigations. So post-hospitalization claims or the pre-hospitalization claims for any subsequent hospitalization, if it ever happens, that value is reduced drastically. Our current focus on negotiations has always been on the hospitalization component. But then that is only 80% of the total claim. We need to look at how we can reduce that 20% of the claim to less than 10%, and then we would have saved overall 10% on the total value itself. And that is why this shift, paradigm shift of our focus from hospital cost to total cost for networking is important. And this also brings us to the point that it immediately means that it's not only hospital whose network is important for us, but we also need to have the network of diagnostic providers, of directly consultants in place. When COVID came up, many of the TPAs and the insurers started doing networking of doctors also. But few of them have actually gone ahead and made it available for everyone. We had networking even done of hotels, which subsequently now have been networking of the wellness providers, because the shift as seen is more on prevention rather than cure alone. And that is why our success strategy, which I generally recommend, is don't look at only the hospital cost, look at reducing the claims incidence itself by offering discounted OP services and as much as possible complimentary OP services for your brand ID card. So if your patient is following up through your portal to that particular provider, it has to be free services, free appointments. So those kind of negotiations is something which we have to look at nowadays, and which are going to give us better long-term results. We have a TPA which has been servicing one of the largest policies for a Navratna organization. And the value which is being offered to those retired employees in that policy is this discounted complete network of pharmacy, diagnostics, and OP consultations. And so the policy also is still always profitable. So this is a proven track record on this particular mechanism. So we also need to start thinking on this nowadays. And then definitely we have to ensure compliance with regulatory standards, which now say that NABH or entry-level NABH criteria are mandatory. Because government also wants to improve the quality of care. So yes, we have to have those, but not just have those. We have to enable the hospital to achieve those. So when we are having audits conducted, we also need to share the audit report back to the hospital. As I said, the relationship has to be of partnership. And a partner always shares whatever are the weaknesses and strengths, so that the weaknesses can be removed and the strengths can be enhanced. So here also the provider networking team needs to share back the audit report. So challenges will be there for the lower payment rates. So we have the solution. We need to make it value-based payment modes. There will be disparities in service coverage. So we need to have tiered network design. There will be regulatory hurdles like cashless anywhere. Though it may seem to be a very good thing from a networking perspective, I feel it is a regulatory hurdle, because now it removes our choice of having network. What it means is now the focus is on each and every hospital has to be a part of network. We don't have a choice left. You used to always have the one of the efficiency parameters for a TPA used to be what is your active provider network count and what is your active provider to passive provider ratio. But now with this particular cashless anywhere coming in, we'll have to simply have all the providers pre-negotiated, onboarded, because we don't know when the case can come in that provider, and then after the case comes during the firefighting is no more a choice, because it will delay, and delay is going to be costly because there are penalties which IRDA can give. In fact, a couple of weeks ago, IRDA has almost done audits for all the insurance companies simultaneously. And what I understand is their focus point was what were the turnaround times for cashless authorizations. And their reports, they are not yet out, but I think their reports are going to be penalizations for delays in cashless approvals. And that is why I again say the two most important pillars for success are going to be our verticals of authorization and provider networking. So the best manpower, best managerial manpower has to be redeployed to these verticals. Because if these two verticals become very, very strong, then there will be a huge success for the organization. So how do we negotiate favorable terms? What can be the key strategies? So I have been highlighting everything. We are just now formalizing it here. The importance of negotiation definitely is for better financial sustainability, because it's going to impact the rates, costs, and patient care quality. So negotiations, whatever are done, they always have to be on fair terms and conditions. And they are the ones which will build strong relationships. Here, the relationship is not of a month or a year or a 2 year or a 3 year. We are looking at permanent long-term relationships between these established entities, the insurance company and the hospitals. So for that, we need to understand the market rates. Competitor contracts, as of now, no one is going to share. But then we have the research industry benchmarks and the regional payment trends which are available. We also know the competitor market rates indirectly, which even anyone can actually derive at. The corporate policies, they generally flow from one insurer to the another. There's a trend of around 40% jumping, only 60% remain loyal to a corporate and 80% remain loyal to a TPA. So around 40%, 30 to 40% jump is always happening. So at any point of a time in a year, you would have got 30% corporates onboarded, which would have been with another provider, another TPA previously. And when we are onboarding, during underwriting, we are always asking for the underwriting claims data. So there we have the opportunity to understand what are the competitor market rates. And hence, the third takeaway is a indirect collaboration between underwriting vertical and the provider vertical. Because such data from the underwriters has to flow to the providers. It gives them an idea of how the industry is paying to a particular provider for a particular diagnosis and treatment modality. India, unfortunately, is not having the CPT coding in place. We are just looking at the ICD-10s. ICD-10 CM in some providers, TPS have implemented. So we cannot have the best understanding, but at least we'll have a practical understanding based on the ICD codes, a generalized idea of what is happening. And most importantly, we'll have an idea of what is the discounting which is being provided against a particular provider. Because that's a separate column in almost all the claims term. And that is why this data from underwriter to the provider helps us to understand the market rates and competitor contract rates. Even if we are not been able to formalize the medical networking task force as I recommended earlier. Second is we have to highlight the provider value quality, the specializations, the patient outcomes. So patient satisfaction surveys are mandatory as per IRDA, which all insurance companies are doing. So as soon as the patient is discharged, or auto SMS, email, and a call is being sent to the patients, and they're supposed to rate the services which they have got at the hospital. So this gives us an idea whenever we analyze for the efficiency and the patient satisfaction for the hospital services. And most of us are publishing it internally as well. This data is being pushed to the IRDA portals also through the insurers. So we also now internally need to understand it. And that is where the partnership becomes important, that we share a summary on a monthly basis back with the provider. I'm not sure how many of us are actually doing it. For the last months, whatever patients were treated, this is a feedback from them. So this also gives them an opportunity to improve on their service standards. And that also helps us in better negotiations. Okay, we are working together. And we have to arrive at cost effectiveness. So one of the propositions in the past had been that generally the cashless rates are very high because the providers generally increase the rates, and they generally increase the rates because they have got added expenditure to be incurred for maintaining a TPA desk, for maintaining a recovery desk from the insurance companies and the TPAs. So that's a risk, and then there's a delayed payment as well. So one of the solutions which was recommended and which few insurance companies are negotiating with the hospitals now is discharge payments. So instead of just giving authorization letters at the time of discharge, they're actually transferring the payments on real-time basis against minimum 5 to 7% discounting on the total bill. Now, this also is a good strategy which can be considered. And this should be rolled out in a phased manner with the top providers who agree initially that if you are providing everything to us through API integration, then you would get discharge level payments also. So then they also need not worry for the credit period or the documentation issues. Everything is done and dusted at the same TPA desk level. So no recovery desk requirements. So the value which is saved, that can be passed on. So risk sharing agreements can also be conducted by them in the long term. So yeah, these I think we have covered. Now, best practices for effective provider management. So definitely technology and automation is very, very important. We use the word AI almost everywhere. Now, I would like to open this forum rather than going into the presentation. बहुत देर से हम सबको बहुत चुप बैठे हैं. I am alone speaking. So now I want your updates either by unmuting yourself or by putting it in the chat box. What you feel is the best way to have technology involved in provider networking or provider management. So anyone can unmute and say, or maybe you can type in the chat box. One जिसने slide देख लिया होगा, they have seen the AI part. But let us start right from our first level. We have discussed many of these things already. Like portal-based application and portal-based all your certifications upload was the first part. Technology. So forum is open for, yeah.
Today what we do is we go to the provider and approach them for the empanelment, which is based on a physical copy or based on the email. And that is what we are practicing as of now. So I would suggest, I think one of the insurance company has done it also. Rather doing this, we can provide different kind of a module wherein the provider can fill in all those details with the videos taken offline and then uploading there, a good one. With all kind of breakups can be given there itself, reception or OT or that can be discussed later also. So those kind of a model can be developed and that can be done while empaneling the hospital. So this can actually ease out the thing. Processing can also happen by the AI itself, whether, as you told earlier also, in terms of the what was like how we categorize or how we do that. So that can be done by the AI and we can empanel or not to empanel, that is can be taken. So that can be a first step. And secondly, even today also what we are doing is very often we interact on emails for reconciliation and all those things. That part can also be given into the portal itself so that that can be a very closed and even more transparent than putting it on email. So these two suggestions I can come up with.
Perfect. Anything else? I'm going to share something very unique here. Or just what this link here. If you see government schemes, they have come out with online forms. TPA also, I was just going to open one TPA, but then I stopped myself because I cannot open any one particular TPA website. So I was just going through this particular thing. So online empanelment forms are available. Whatever you do, this is something which needs to be encouraged. And even if you have got an email, nowadays there are email readers. So based on the words and the structure in the email, the emails get segregated into different buckets. So those bucketing and then transformation of that directly into the database is something which needs to be promoted. So right from your request stage, it's the moment, or if someone has sent a request to you even by say email, the reply has to be, we are very happy to receive your request for empanelment. Kindly fill the form on this link. Yeah. And the moment those emails go, then we get everything directly in our database, and then auto comparisons can happen, benchmarking can happen, and the hospitals also understand where they are. Second is technology involvement after the request part has to come directly at the credentialing part. Now, the hospital providers or the doctor's database, if it is available with us, we also have the registration validity information available in public forums. So certain programs can be written whereby we can actually browse this information and confirm the validity of that directly instead of allowing it to be a manual task. Because a big provider or a big hospital would have more than 200, 300 doctors working with them. And that is why automation of that particular thing is very, very important. Otherwise, generally what happens is we never check it. And the moment we never check it, the result is that many a times services are being given by those who are not qualified to give that service. Like the other day, from your team itself, if I'm not wrong, from Indore or Bhopal, someone was sharing the unique case of the hospital employee itself who had created the provider billing for the services which were not given during the COVID period and how they had caught it. But if technology would have been available, we should have assessed it, then it is very easy. Third is when these certificates are uploaded of the doctors, each of the certificate carries the doctor's signature on it. And with simple Python-based scripts, we can always validate those signatures with the signatures on the claim documents that we get in future. That is why technology to extract and counter confirm not only the provider information which is received on the application form, but sorting it for future usage is important. And that is why AI-driven interventions, verifications, they reduce the errors and the delays which can be happening in the process which we are following currently. And then definitely the document management system, the document tracking system, following up for renewals and compliances. Some TPS, they promote themselves as better than the other TPS because they have got providers who are still working on 5-year-old rates. They feel that it is a plus point for them that they are able to get the providers agree on lower rates. But then actually that is an inefficiency and not an efficiency. Because the provider which in terms of necessity is agreeing to a lower rate is at the same time allowing certain higher and unrequired billing heads created to offset the losses against the 5-year-old tariffs. The consumable usage, the medicine usage which such providers have is higher as compared to the generalized industry usage. So it really feels laughable that certain TPAs are promoting if we have hospitals working on lower rates. But still their average claim cost is higher because it always gets offset. So we have to increase our efficiency. So this AI-driven automated system which triggers these automation, these renewal requirements, renewal requests is something which is useful. And again, this again goes towards the ethos of partnership, that even before the hospital may be thinking of revising their rates, we are reminding that we are due for revision of the rates. And if somehow or the other we can have the rates in sync with the rate revision cycle of the hospitals, it becomes all the more beneficial. So technology usage is very, very important. Second is we need to maintain proper proactive compliance and monitoring. This system is very, very important. So we have to regularly audit the provider credentials. Now, this is possible when you have your local level leadership empowerment. Go back to the slide where we were talking about Ashta rule. Your local employees, whether it is of a marketing vertical, or operations employee, or anyone, I always request that we should have a target of each employee visiting a hospital at least one day in a month, irrespective of his profile, for 2 hours at least. And when that employee is visiting that hospital, all he has to do is he has to go to the TPA desk, say hi, hello. He has to go through the list of the patients who are admitted as per the insurance company authorization database or the CI claim intimation database, and want to go and meet those patients, greet those patients, give them get well soon cards, and just browse through the files, even if he understands nothing of it, and come back. Now, what this system does is it gives huge results. One, the patient and the relatives, they feel that the insurance company is caring for them. So loyalty develops and they give more referrals. So the business, the top line increases. But look at the cascading effect it is having on the hospital. When they see that the employees are coming and they are seeing the patients, the tendency to abuse reduces. And if these are qualified employees who once in a while discuss on case management, then results are far, far superior. And when these employees are visiting, they are going through different departments. They're actually auditing the provider infrastructure availability. So the hospital audit also happens simultaneously. So this is something which is a very unique methodology. And I'm really happy that even PSUs have started implementing it in certain smaller DOs and branches. They are also going now and visiting patients. This was something which Star used to do in its earlier stages when they started off. They used to ensure that each of the patient who is hospitalized used to be visited and given a greeting card. So it's a multiple beneficial, simple one task. And we also actually understand what is happening in the hospitals when the employee is visiting, and we understand the importance of our role. That though we may not be clinicians, we are equally responsible for the patient care because our decisions impact the kind of care which the patient is going to get. So delays on our part can delay them. Mistakes on our part can create more hassles for the relatives. So multiple benefits. And that is why this simple recommendation of local leadership empowerment. And finally, it is the efficient onboarding enrollment processes which is going to create a uniqueness for us. So the application workflows have to be standardized. And not only that, we should, once the hospital is empaneled, provide training and support as well to the providers. If our websites are slow, the hospitals will not be ready to use our websites to upload the authorization requests. So first and foremost, we should try to have an API integration. If API integration is not failing, then our pipeline for our websites has to be so strong that it can be very fast. And the hospitals are more than willing to use it. And even if they fail and they simply continue to sending the emails, we should have the system in place which reads the email content and converts it into standardized databases. So this automation, this technology use is important, which is going to foster long-term relationships. There's going to be collaborative discussions, which will be fostered in the long term. And the moment we have such environment, definitely at the time of renewal, we'll always have better favorable terms. And if unfortunately there are disputes, there are delays, then definitely at the time of renewal, the hospital is not going to be favorable to us to give us anything more. And that is why this open communications is very, very important. Today, we may feel that we have saved X amount, but that savings of X amount actually results in long-term expenses of minimum 1.2x during the next renewals, because the hospitals feel that there's going to be deductions. So all those get added up by the hospitals during their own tariff revisions. And who finally bears for those tariff revisions? It is we. So let us overcome especially these 4 challenges: the delayed credentialing challenge, the regulatory compliance issues, the negotiation roadblocks, and the inconsistent provider data by using technology. This is very important. Is my presentation visible? Nahi hai. Okay. I want you to go through this. Yeah. This is something very, very important, which I generally request everyone to go through. How can we be successful? So first is deputing right fit manpower. Now, right fit need not mean doctors. This is a misconception. Right fit means manpower who is trained, who understands the hospital's dynamics, who understands what is hospital financing, who is having good communication skills, good negotiation skills, who is very patient. Such are the right fit candidates for the networking vertical. So irrespective of their qualifications, they can be trained. There would be standard operating procedures, case studies which are discussed. In fact, when we started off a new vertical in our organization in 2008, I had this one boy who was just 10th passed. He had not even applied for his 12th. And he had joined as a office assistant. But then whatever work used to be given to him, he used to do it very perfectly. No deviations. He used to be always patient. So we thought that let us try to give him something different. And we actually trained him on provider networking. And then he started going to the hospitals, the diagnostic centers, not hospitals, diagnostic centers. And the results were huge. We used to empanel those centers which were ethically very, very good, patiently, and highly negotiated rates. And we observed that the amount of abuses which used to generally come, we have a internal criteria of abuse versus employee empanelment user. which we have to determine the performance of the employees in the networking department. So we have three criteria. What is the average cost? What is the number of abuses reported? So these are two important criteria in there. So those parameters came out to be very, very good, better for that. So education is not important. The training, the attitude, the right fitment is very, very important. And we have to give them case studies. Secondly is that networking does not end with enrollment. It starts there because now when it comes to monitoring, that becomes important. So there has to be automated triggering of claims even to the provider team. So they have to be triggered on the basis of costs, variances from the tariff which has been agreed. So all such claims should go for a study to the provider team, and they should be actually discussing back with the providers that we have agreed. So why repeated such things are happening? So if there is any differences of opinion, differences of understanding, that has to be resolved immediately. And as far as possible, we have to try to have an API integration of their HIS with our whatever software we may be using. With most of the providers now on NH6 platform and the insurers also on NH6 platform, if that has worked, why it work only for NH6? It can work for all claims. It's as easy as that. And that also makes us come to the important point of monitoring productivity. Beneficiary audits have to be conducted. So it has to be actually on-bed verifications of the patients, as I mentioned. That gives us an idea of what actually are the services which these empanel providers are giving and how they are beneficial to provide return to OT, return to ICU or the critical care unit, and rehospitalization ratios. When DP audits are happening nowadays, the insurers, especially one of the public sector insurance company, is actually monitoring the LOS and comparing the LOS against the different amongst the TPAs and sharing data as a feedback. That if your case management, you could have done case management, then on the LOS benchmark, you would have been better. So all such aspects with beneficiary audits, patient satisfaction, we can understand. Hospital audits, definitely, but they need not be only infrastructure audits. They have to be utilization audits, gradings, and MOU compliances. As I said, one of the clauses in MOU compliance is that we have the freedom to audit the software of the hospital directly or through any of our representatives or through a TPA. And if we come across any discrepancies, the hospital has to pay us back. But no one has used it till now. Treatment audits is again a part of the provider networking vertical. They have to have a relevance of treatment, compliance to quality care, compliance to standard operating procedures. And for all these things, data analytics is important. So analytics vertical has to be working as a support function to the provider networking team, making them understand procedure utilizations, hospital utilizations, triggered cases, successes, failures. Many of the hospitals are practicing standard treatment guidelines and standard treatment protocols. So reports should be able to be generated. How many of them are following it? How many of the hospitals are following the mandatory documentation? And we should be ourselves coming out with adjudication guidelines and enabling it to the hospitals. Just like Jivandai or NHA or down south, the Chief Minister's Comprehensive Health Insurance Scheme, they have got guidelines now for all the packages. And the hospitals follow them. Angioplasty with failure, unless it is a PAMI, they ask that, has there been a failure of treatment, conservative management? And then and only if there is a blockage above 80%, they allow for angioplasties. So treatment guidelines. And if they are shared already, it helps in reducing our overall interventional costs. And then whatever be the triggers for tariff deviations, you have to also look at the success ratio of those triggers. And whatever are the new trends, you should be always open to understanding those new trends, especially from billing perspective. As we have seen post-COVID, the average bill costs have increased tremendously because all the hospitals have started concentrating more on disposables instead of having the CSSD usages. So what are the new trends coming in? Robotics, everyone is coming out with robotics, but is it really beneficial, and which robotics is being used? And whether it is only programming which is being done or actually robotic surgery which is being done. The other day we were talking about radiation oncology claims becoming very high. And that too, there we find that almost everyone is asking for the Rapidac claims. But whether it is Rapidac only which is actually being used, or is it simply your IGRT which is done? Very minimal difference. So is our team empowered to understand that difference from a provider networking perspective? Do we have the employees who have empaneled the radiation units know what is the difference between do and can they capture it? Because it is very, what else is minute difference on the radiation plan level, where on the top corner we only see the change in the degrees of the machine and nowhere else. So that is why many of the times the radiation bills, though they are for IGRT, they are claimed for Rapidac because they are having a better package rates. So do our employees understand it? And are we empowering them? Are we using this market intelligence? Are we having such success ratios? Is something which we have to develop in our organization. Because if we develop it successfully, then only sky is the limit. But then we need to develop it. And then this we have seen previously. So let us understand that for robotic surgery, for provider management, it's not necessary that we have actually got to be in the provider team only. We can be in any vertical. We just have to keep our eyes, our ears open, and then understand what is happening on the ground level. Thank you very much. I keep the forum open for questions, which you can raise. We'll have question answer sessions now. So we can talk a lot. I've been having a monologue after many years today. So any questions?
Any questions, team?
So these are my credentials. You can contact me anytime. I'm always available. As I say, I am a servant of the industry. The industry has given me so much. So I just have to give back whatever way I can. So you can contact me anytime.
Thank you, Dr. Sachin. Any questions, team, from your end? If any comes in my way, I think I'll share it across with you.
Sure.
But indeed, Dr. Sachin, thank you so much for this session. And I've been listening to it, and definitely, yes, it's been invaluable to take me myself. Vikrant, you've raised your hand.
Yeah, only one question.
Yes, please.
Doctor, do you have any update of government thinking of any standardization of tariff? Because each hospital has a different tariff and different nomenclature, which is very challenging for insurance company.
Yes, I can share something here. In fact, if you remember, the whole Rohini started project in 2008, wherein government wanted to have this standardization. So while the Rohini registry was created, at the same time, in the standardization of health insurance manual, government through IRDA has already published standard billing codes. So that was the first stage of going towards standardization. Stage 2 was the Clinical Establishment Act, which again mandated standardized billing for everyone. But being a federal structure, a few of the state governments have not agreed to it, and state government level different acts came in. But now the tide is changing again. They went through the third stage. They brought in the National Health Exchange platform. So again, National Health Exchange platform is not only just exchanging, but it is going to be slowly and steadily has created what I'll say a environment of all the HMIS providers in the industry together. So that is the level through which now the standardization is being planned, since the providers themselves have not openly accepted it. And if the HMISs across, there are so many HMIS providers, but almost all the major providers are onboarded with the NHCX now. Thirdly, the NHA is coming out with one draft tariff format as well. So it's going beyond the PPN now, the National Health Authority. So the draft tariff format is something which is likely to come out, where there will be codification of everything, and we may accept the ICD 11 as well as the CPT coding as mandatory in India in coming 1 or 2 years maximum. So whether it is cash payment or insurance payment or corporate payment, the ICD and the CPT mandate may become a real thing in India in the coming 1.5 to 2 years now. And all the HMISs are going to be compatible for that. Yes, Vikranji.
So regarding the CPT, I mean CPT requires documentation, which is there in US, but in India, I don't think that documentation will be provided because we need surgical notes also to put. So I don't know how compatible the provider would be, and how I mean they would be. I mean they will adapt to the changes. That's my.
When ICD was introduced in 2002, the providers were not agreeing. But now we feel that if we see our own data, insurance companies' data claims, more than 35 to 38% of the hospitals are giving ICD codes in their discharge cards. So that's a huge achievement. So similarly, there will be resistance to start with, but now that it is going to become a mandate to the National Health Authority, it will have to be followed up. So it's not that, okay, today I am mandate and from tomorrow I'll start getting it. No, it's also going to take its own sweet time of around 5 to 7 years before it actually shapes up with 100% compliance level. And that is why these are small steps, baby steps in those directions which have happened. So NHCX is one step, and now that step is going to happen. With also the current dispensation, the political dispensation we have, the discussions on the Centralized Clinical Establishment Act and mandating it across all over India is also in discussions. So even that is something which may find very soon, though health is a state subject. So central government may come up with this mandate as well. That is why I said 1.5 to 2 years is going to be a very exciting journey in health sector.
I agree with you. Thank you, doctor.
Thank you.
So we are talking about 100% cashless. We are trying to achieve that. We have started something called Anywhere Cashless also. But when I look at the data, what I can see is that maximum of the cashlesses are happening only in type 1 kind of a city like Ahmedabad, Delhi, metro cities, or this. Majority of the data are coming from here only. We have sold the policies in remote locations also, but remote locations are having their own challenges. Like providers are not actually willing to go for the extending cashless facility. What they are doing is they are extending credit to their own customers, because when we go to a city, small cities, so they have their own kind of similar, each and every people know each other, and kind of cashless has been extended to the direct patient, though they are having the insurance.
So how can we achieve a kind of a cashless which comes as a formal thing? I believe that cashless is already there, but that is a very informal setup in remote locations.
That is why I said it's a trust deficit. For a hospital to have a cashless tie-up with the insurance company means additional headache of having a TPA desk for getting approvals for the cashless, and then having a recovery desk, do the documentation, send it to the insurance company, and then wait for the payment to come, and then reconciliation. So smaller hospitals in smaller cities who are very happy with whatever patients they get, for them it's not a anything beneficial, but it's a burden for them. So they generally like to avoid such burdens. So the solution lies in how we can make this system much better, much comfortable to the hospitals. First part would be, instead of asking for documentation in our formats, the rates as per our formats, we simply tell them whatever you are giving to the patient at the time of discharge, give it to us. And then based on that, we take the decisions and tell them we are going to make the payments immediately. As I said, we need to arrive at the situation of discharge day payments. I'm not talking about approvals within 15 minutes of authorization. I'm talking about actually claims processed on those scanned documents or digital documents and making payments within 30 minutes to the hospital. So when we reach that level, there won't be any hassles for the hospital left anymore. They won't have to have a separate desk for doing recovery, separate desk for accounting, reconciliation. So for them, since it's a no more hassle, no more risk, they will be willing to extend the cashless to us, cashless to the hospital, the patient, as well as have a tie-up with the insurance company. So a different way to look at how the networking and the claims processing is going to happen is important. And for that,
So
the trust has to be built upon the providers. And even if we
can
start,
it be something like making a green channel for these remote locations?
it has to be a
Not for
green
everyone,
channel.
because manipulation also comes into the
Yeah,
picture after
that is what I was going in. The moment we start doing this, the next step has to be we give it, but then we increase our investment in our abuse detection vertical, wherein then they actually understand whether there is any abuses which are happening. If we want the hard copies with us, as per our internal guidelines, then we need to have prepaid couriering facility made available for these hospitals. Just like Amazon and the Flipkarts, if they want to pick up anything from the I'll say the return of the package, they don't charge it to us. They provide it free to us. So similar has to be the situation wherein we don't have the hospital to spend on those, sending all those documentation or anything. We tell them you just simply drop it off at this place or someone will come and pick it up. And then we do it. And then we invest in the abuse vertical, wherein they have to understand, they have to track it, they have to do the analysis and trigger if there is repeated offenses or repeated trend which is coming in. So linear regression studies will be very, very important against such cases which will be coming up. And if there are any deviations which are observed here, since cashless anywhere is not something that, okay, you give request and I give cashless. No, still there is an agreement stage which is required, though it could be a simple one-pager agreement. But an important clause of that agreement is, in case of any unethical observations, any abuse, any manipulations, the hospital is agreeing to be paying back the amount with penalty. And then the formalization of the agreement that you will be working on this pattern and the regular agreement is getting negotiated. So that is why I said we need to increase the network now. And the best way to increase the network is, instead of just concentrating on doing networking of the hospitals, we should start on move our concentration on networking of providers, the doctors. So let the doctors go to any hospital. Our network is with the hospital, the doctor, And the doctor, since he is taking the patient to the hospital has faith on the doctor. And we are doing cashless with the doctor. So it is formalized. So we are fulfilling the cashless anywhere requirement as well. So multiple different ways by which the different TPAs and the insurers are tackling this issue right now. Because finally, from the 70%, we have to reach 100%. 100% possible when each hospital, each doctor compulsorily is a part of the hospital the insurance network. But the resistance is going to be there as long as there is a headache of additional documentation and delays in payment. So for that, insurance companies have to evolve for discharge payment methodology.
Right, sir. Thank you.
Thank you very much.
Any other questions? Anyone? Okay.
So if there are no more
So
questions,
can we call it? Yeah, we can. Yeah, wind up. Thank you again, Dr. Sachin, and thank you, participants, for being here. I pasted a link on the chat box. Please fill that up. That's mandatory for your attendance. And second thing, Dr. Sachin, I would request you to share an answer. I think Yogesh will get into with you.
sure. Thank you very much.
Dr. Sachin?
Yeah, thank you very much.
Team, am I audible? Yeah. Okay. Yeah, please share the deck, Dr. Sachin.
Yeah, sure. I'm sending immediately.
Yeah.
Okay, thank you.
Yeah. Thank you. Thank you, everyone, for joining in. Please fill up the attendance form, which is pasted on the chat box. Thank you. Thank you, Dr. Sachin.
Thank you.
Thank you.
Thank you very much. So thank you very much, everyone. We'll meet again tomorrow for further discussions. Hare Krishna.